Hello, listeners, and welcome back to our podcast. Before we start today's interview, I wanted to remind you we're having our annual meeting in Las Vegas September the 1st through the 5th called Ortho on the Strip. We would love to see you there. Please sign up and register as the spots are going quickly. Listeners, welcome back. For the next couple of weeks, we will be blending the old with the new. I recently contributed to an article on bone health in a publication called Community Health Magazine. After seeing my print in this article, I thought it would be a great time to revisit a podcast on osteoporosis. We did a podcast on osteo several years ago with a PA named Catherine Sweeney, who's a colleague of mine who does bone health for my practice. And Catherine told me when I was asking her about the podcast that there are some new and exciting updates with treatments. The basics are pretty much the same, so we're going to rebroadcast or republish the first part of our interview from the podcast from before, and then a new recording on treatment updates and what patients can expect as far as sequencing of treatments. Catherine specializes in bone health and osteoporosis management and is a certified clinical densitometrist. Catherine, welcome to our podcast.
Hi, happy to be here.
This week's topic is on osteoporosis. I recently had an 80-plus-year-old patient who was standing at the door, answered the door, twisted and felt pain, and had ongoing pain in her hip and knee and back, and it got so bad she came in to see me. And I got screening x-rays, and she had a femoral neck fracture just from standing and twisting. That's her osteoporosis. She's had some compression fractures, and it's been really debilitating for her. So I wanted to have a talk on osteoporosis. May is National Osteoporosis Month, so it's a timely topic. I think most, if not all, of our listeners are familiar with osteoporosis and osteopenia, but it's a tough problem, and it remains a significant problem throughout the country. So, Catherine, I was hoping you might review for our listeners bone pathophysiology and cellular and hormonal regulation of bone metabolism.
Absolutely. So, osteoporosis essentially means porous bone. There's literally not a lot of bone there. This is regulated by a process of bone resorption or bone loss and bone formation. Our bodies are constantly losing bone and rebuilding new bone, and losing bone and rebuilding new bone. That process is regulated by many different factors in our body, predominantly, though, by the hormones estrogen and parathyroid hormone, and to a lesser degree, testosterone. And these hormones and these signaling pathways either stimulate osteoclasts, which are the cells that are destroying the bone or resorbing the bone, and they regulate the formation of osteoblasts, which I call those the bone builders, which essentially are helping with bone formation. So it's a complex process of the osteoblasts and the osteoclasts talking to each other through various signaling pathways that then allow the body to essentially get rid of the old bone and build some new. And osteoporosis is when there is an imbalance where the body is resorbing bone or getting rid of the bone faster than how quickly it is building the bone. And so you get a net loss. And a lot of that is, again, regulated with estrogen, which is why this is so much more prevalent in women. When we lose estrogen after menopause, that significantly lowers the rate of bone formation, thereby putting a woman more so at risk for developing osteoporosis.
Let's talk about diagnosing osteoporosis. I know DEXA scan has been around for a while. Is that still the gold standard? And along with that, what other modalities are available? Lastly, third question would be, what are the indications for ordering bone mineral density testing?
DEXA is still the gold standard as far as screening and diagnosing osteoporosis. It's a simple test, uses X-ray technology, takes about 10 minutes. There's no no dye, no needles. The patient lies there essentially on the table and the machine moves above. And that is tool that we have to not only screen, but also diagnose osteoporosis and also help us to monitor patients when they have started treatment to see if the treatment is efficacious or not. Other modalities we have are CT scanners. There are some CT scanner programs that can be added to those machines to help diagnose osteoporosis. And there also is some MRI technology. Some common one that some people have had is an ultrasound of the heel. That is a very convenient, portable way to potentially do some screening for osteoporosis, but truthfully is not reliable. And you certainly cannot make a diagnosis with that modality. As far as who should get a scan, the current guidelines recommend a bone density scan, truthfully, for any woman over the age of 65 or any man over the age of 70. Of course, those ages can be lowered if people have any of those risk factors for osteoporosis. So if someone has already suffered a fragility fracture and they're postmenopausal, if someone has been a lifelong smoker or is on chronic prednisone for other disease processes, there's multiple reasons that someone should be screened for this disease.
Let's talk about fracture liaison services. This has been around our conferences. So, my experience in orthopedics is we treat the fractures, we're not preventing them. That's always been the mindset, and it's a tough one to fix. I think that fracture liaison services are very important for orthopedic groups, and I was hoping you might touch on that a little bit.
Yes, fracture liaison services are certainly becoming a little bit more widespread. And these are basically programs that practices can implement to try and essentially stop or close the treatment gap of osteoporosis. As you've mentioned, unfortunately, this is a very underdiagnosed problem and even more so an undertreated problem. And fracture liaison services can help not only identify patients who need to be screened and treated, but then also help follow these patients. They are often led by a physician assistant or a nurse practitioner. This is actually a really great opportunity for PAs and NPs to take on a little bit more of a leadership role. And often there is a nurse or medical assistant, which helps with the coordination of care. And of course, often teams of physical therapists, depending on your practice, or other healthcare providers that can help form a team for these patients. So, the goal of the fracture liaison service is to number one, identify the patient who qualifies to be screened, then hopefully implement some treatment if needed, and then follow through with the patient and coordinate their care with their primary care doctors or any other specialists. So, it's really a team, hands on approach. These fracture liaison services take all different forms due to the nature of how we all are practicing in different areas and hospital settings versus outpatient clinics or primary care or orthopedics. The framework may look different for each practice, but the goals remain the same. And there's some really lovely blueprints out there now for providers who want to start one of these programs. The American Orthopedic Association has a very robust program called Own the Bone. So a practice can join Own the Bone and they will be given tools and resources to help start one of these services. The National Osteoporosis Foundation also has a FLS program where you, again, as a healthcare provider, can get resources that you need to start your own FLS service. And the International Osteoporosis Foundation has a program called Capture the Fracture that organizations can join. And they have a lovely program where you also can get a mentor of sorts, another practice who maybe has been very successful with this so far and can help implement these programs. Our fracture liaison service here at an orthopedic practice certainly makes great sense. You're already seeing these patients for fractures, presumably. So it's a great way to then be able to capture those patients and helpfully help them prevent another one from happening before they even walk out the door. Like you said, the patients are there, and this is still such a widely underdiagnosed disease. And I think as PAs can really do a great service in helping these patients and identify these patients and also take a bit of a load, off the primary care doctors as well and providers who have so much on their plates already because these fractures, and especially those hip fractures, gosh, they can be so debilitating for patients. So many of them will need walkers or canes, or will have to go to a assisted living facility. They lose their independence. They lose all the joy of what the activities they used to be able to do. And it's really devastating for these patients. And so if we can prevent this for them, keep their sense of independence, that is huge for the patient. Would just be sure to educate yourselves on what these risk factors are and see, if have that conversation with the patient. If you're seeing someone who just fractured their wrist, hey, this could have been related to osteoporosis. Let's get you screened. We don't want this to happen to you again. So just having that awareness, I think, will help close that treatment gap that unfortunately is still quite wide right now.
Listeners, please stay tuned next week where we discuss the new and exciting treatments of osteoporosis and sequencing of treatments, which is where a lot of osteoporosis research is being conducted. I hope to see you guys in Las Vegas. We're really looking forward to a big meeting. Please check out our website and check your social media for details.